So we want to thank you for doing that. And I want to move along here. I want to thank our panelists on the next group to talk about something that I think is relevant for everybody, really, and particularly in ophthalmology. And we've been basically, for most of us, basically a month where elective and non-urgent surgeries have basically been stopped. And whether you're a resident or a trainee or a seasoned surgeon, being off for that time does raise a lot of concern and questions. Just in my own neighborhood, we've had 2 surgeons who've retired, for example, older surgeons who've retired because they just felt, you know what, they can't get right back into it. There's concerns about the practices during COVID and after, and they've stopped. And so I've asked this group of illustrious panelists who have a lot of different perspectives and vantage points to speak to this point about staying sharp. We're going to make it casual with some discussion as well as some presentations. And so we've already heard from Havo and Arsham as well. I want to introduce Nicole Fram, who's joined us from LA, Stuart Stoll as well from the LA Beverly Hills, and Valentina Lozano, who is here in Toronto, who loves the weather here as well. So maybe we'll start off with Havo about just your perspective in terms of just how you're approaching this time that you've been away from surgery.
Great, thanks guys. Can you see the slides?
Yep.
Okay, perfect. So yeah, this has really been about staying afloat, and as you know, I'm a surfer, and this I thought was a really great visual of what's kind of happening right now, trying to keep that thumbs up mentality. So this was your life before COVID 2019, where of course different percentages for everyone, but office most of the time, and then some OR and ophthalmology meetings, other stuff, family a little bit less, and then 1% for yourself. And then COVID comes, and 88% of the time you're just reading about it, and the rest is a very minor percentage. But the truth is, this 88% reading about COVID is really a time to be alone. So if you don't know what this is, you cannot come out of this pandemic without having seen the Netflix series Narcos. This is Pablo Escobar when he was forced to isolate during the series. But more seriously now, this is a crisis. And I love the Chinese word for crisis. It's comprised of 2 symbols. One of them is danger, and the other one is opportunity or a changing point. So this is something that we might want to consider and approach this with this philosophy. So I think the most important thing here is trying to create a sense of normalcy, which is going to provide us some kind of emotional safety. So when it comes to the office and clinic, and this might be the part that you missed the least about your previous life, but something that I've found very useful is to, because I have all of this time on my hands, get to know your staff a little bit better. Those of us that managed to keep some of your staff or people that are still working for you, whether it is at the office, if you're going to the office to see a couple of patients, all of a sudden you have all of this time. And I think if we can all agree on one thing is we hardly ever have time for anything in clinic. So this is a really good time to get to know your staff as people, to encourage better human interactions. I've also been playing a little game called Look Around, and I basically try to notice something new in my office. And you'll be surprised if you play this. There are so many things that you fail to notice in the office because you're always running around, whether it's a crack in the wall, or something that needs cleaning, or even like a picture that you had never seen before. You could rearrange your desk. And something that has been incredibly useful now has been trying to improve things about my practice. So I try to set out every day trying to improve one process. So for example, today I signed a contract with a company that's going to help me with my electronic referrals for physicians and optometrists. You can improve a procedure in the office when it comes to staff, and of course you could improve your workspace. So last week we brought some plants into the office, and it looks a lot better now. So you also have your OR, which is what we all miss the most. And a good way to stay sharp is to watch a video of a new technique, or read a book, or read a paper about a new technique every day. Editing your videos, of course. I don't know about you guys, but I have a bunch of videos that I never got down to edit. So it's been quite fun just digging into the old archives and trying to, find interesting stuff to show for more webinars. And another incredible thing is pick up a hobby, especially something manual. I think one of the things I miss the most about the operating room is that capacity to use my hands and be creative. So, choose whatever hobby you like the most. You can paint, you can draw, you can do sculpture. I personally shape surfboards, and I've been doing a little more of that, and it's great. I keep myself busy that way as well. Um, Let me repeat that here. There you go. Of course, family is probably the best part about COVID, or the only good part is we get to spend more time with our family. Those of us that have the luck to be close to the ones we love. So of course, spend a lot of quality time there. You don't know when's the next time you'll be able to hang out with your loved ones and spend quality time. If for example, my parents live far away, so why not call them? Do some more Zoom with your family and with all the people that you love. Of course, when it comes to your ophthalmology meetings that we all miss the most, I think Prism IRANS is pretty much taking care of that right now. And the social part of it is something we all miss. So we're now launching, from the people that brought their IRANS, this Prism Happy Hour. So everybody grab your favorite drink. And after this webinar, we're going to have an hour of socials, because after all, thank God it's Friday. And no, it's not. Who fell for that one? It's Wednesday. So maybe we'll save that for the Saturday webinar. We're not doing it today, but maybe we should. And of course, the most important part of this talk for me is you really have an incredible opportunity in this crisis to focus on yourself. So focus on getting better, focus on coming out of this better than you came in. And you can choose what to do. I think working with your mind, working with your mindfulness, calming yourself, whether it's through meditation, whether it's through a specific religious technique that you might have, a religious preference, prayer or whatever, it's a really great time to focus on yourself and on your mind. Of course, focus on your health. Working out is amazing. Now you have no excuses to start that workout routine, 1 hour a day. Get yourself on some videos and whatever kind of program. Try to stick to it, and get moving. It's important as well. Your body is important. It's your shell. Great chance to self-assess. Sit down, look at whatever is important for you, your practice, your surgery, your skills. Self-assess, write it down. Look at how far you've come. Think about what you were doing a year ago. How have you improved? Where have you not improved? This is the chance that you have to see where you want to go next. So dream big dreams. This is not going to last forever, but the changes that you might achieve in this period will. So set new goals, dream big, and then think of a plan to achieve these goals. Because ultimately, it all depends. It's very important to have a schedule as well, and try to stick to it. That made a big change in my life. I only started that, to be honest, about a week and a half ago, and it has been amazing to have a fixed schedule where I try to stick to the timeline, and it really provides a sense of security. Try to limit your reading about COVID to 1 hour a day at most. I promise you that is enough. And just remember that your ability to choose gives the situation meaning and not the situation itself. Thanks, guys.
Thanks so much, Havo. Great perspective. And I was going to look at your pie chart. I think in the pie chart, you had to add a new category for webinars, right? That's kind of been the amount of time. Arsha, I wonder if you can load up your presentation. If you want to share a screen, you can take over from Havo's screen. And while Arsham is loading it up, I thought it'd be really good to get Arsham's perspective here. Arsham Shabani is the residency program director at WashU, as well as he runs the glaucoma fellowship at WashU as well, and is well versed, of course, in glaucoma as well as all kinds of complex surgeries, and has a real love for teaching. So I thought it would be nice to hear from you, Arsham, about what kind of things you've been telling your residents and trainees and your fellows, for that matter, as well, in terms of staying sharp.
Did you guys see that?
Yeah, thank you.
Yeah, thank you. There's one thing to tell them something, and there's another to have them listen. So it is kind of counterintuitive. We're staying home, and then we're expected to stay sharp. I didn't really know much about the data in here. I think all of us have this trepidation that if we're not doing what we're used to doing, that we get that sense of feeling rusty. Well, is there literature on that? Let's just talk a little bit about kind of knowledge bases. If you look at medical student clerkships, this was 2 smaller programs in the Midwest looking at how their medical students performed when they had a break in the clerkship to study versus if they didn't. And you can tell on the surgical clerkships, the students felt like the break actually helped them study. But if you look at the data, the 2 groups, whether they had a break or not during the times that they were on service, it didn't really change their overall average scores between the groups. So test-wise, they ended up performing the same. What about surgeries? We don't really have good data regarding ophthalmology, but there's 2 studies I want to kind of point out. This one was done in a French hospital system, had a ton of patients, so almost 9 million patients here. And what they looked at was over the course of years, was there a change in surgical mortality related to vacations? And in France, a lot of their workers end up taking sometimes weeks off, and it typically occurs around the August months. And they try to correct for variables like weather and surgical caseloads. But looking at this data is kind of interesting because what they found was what they called an August effect. So during this time, the mortality did increase slightly. Now you have such large data, these small changes can come out and be positive. There's a lot of issues with studies like this. But one of the interesting things was this peak was kind of consistent time and time again. And they did talk about how staffing issues were reduced during this month. And generally, the more senior or experienced people would take vacation, and the less experienced people would be there. And that could explain some of these things. So I looked at that and I was like, that looks kind of damning. Is there anything else going on? Well, our friends up in Canada, and Ike, you know how much I love that area here. I actually like this study a little bit better. This was looking at administrative data from Ontario. And they compared patients who had larger heart procedures or coronary artery bypass grafting between two groups. The first group were patients that had surgery immediately after their surgeon came back from vacation. And then the second group had surgery by surgeons that really had no vacation before or after the surgery, because you could say maybe some people are going to check out right before they leave town. And they used propensity scores just to try to reduce a little bit of the selection bias, since they're looking at these things retrospectively. And really what they found, there really was no difference in mortality, not even in surgical time, ICU or hospital stay between these two. And I'm more in line with this. I do think that you'll find yourself feeling a little bit more uncomfortable in the operating room. I don't know how that's going to transfer to ophthalmology. But what are we doing? Well, one of the things we're trying to stress, and it depends on how well they get into it, but is wet labs. And I think what you need is to make sure that your hands and brain are used to working together, even under minor magnification. You don't have to be doing the steps of the surgery that you're doing, but just keep them working together. It's exactly what Havo said. It's the videos, thinking about the surgical steps. Ike, you and I have talked endlessly about surgery and what makes great surgeons, and it really is their ability to think. 80% of it, in my mind, is mental over their actual hands. And much of this comes about by studying and looking at videos. And again, like a good pool player, you're trying to set yourself up for the next shot. So even if you take a little bit longer to make your first step better, I think that counts. But the thought is where we really need to be. And then this type of stuff, the conferences. I mean, we have coordinated grand rounds between academic centers, US, international, things like this. This keeps us having ophthalmology top of mind, but it's the e-socialization that I think is really important during times like this. As we start to kind of think about it, this was one of the Zoom conferences we had where we're talking about contract negotiations for residents, right? Pretty boring. When you start getting into, surgical talks and case discussions, I think it's important to keep it lively. This is what we need to be doing. And it's been a lot of fun for us. And I think you need to make sure that you continue to have that human interaction. But I really appreciate what you guys have done. I think you're spearheading something that is probably going to have more impact in people's lives than what you think.
Arsham, why is there two of you in this picture here?
Well, I took two different screenshots, man. I had to show you that we're happy more than just once.
I think about cloning. Cloning is the answer to solving problems. Thanks, Arsham. Great pearls. Great to see the data there. And I think you're totally right. And I'll give Valentino a load up a presentation while we're transitioning here. Too often we get locked in, especially as residents and fellows, thinking about I got to do something to learn it properly, and often we end up seeing trainees do things hundreds of times and not necessarily do them very well or as well as they could be. And the mental part, man, I mean, that's so easy for us to say. I realize that. Many of you are saying, well, it's easy for him to say that, but I can tell you, Arsham, I agree with you. When we look and see how those that can really pick up things quickly, they do it because they can process it in their head really well. And get mindset training and learning and putting yourself into different scenarios while you have time now, I think it's a great idea to do that. But there's, of course, value in learning physical techniques. And I think that's where things have changed dramatically, certainly since when I was training back as a resident, in the ability to use artificial eyes. I mean, they take a lot of the mess out of the cadaveric eyes. The cadaveric eyes are not as amenable for certain things. And of course, there's a whole other issues around handling. So I wanted to get Valentino Lozano, one of our fellows, and also we're privileged to have Stuart Stoll here as well, to talk about artificial eyes and specifically simuli. I met Stuart many years ago, and I think he was a real visionary and really understood the need for physicians and those learning new techniques as well as industry to bring in artificial eyes and different settings to learn different techniques. And I think, boy, if you haven't had a chance to use these now, there's no other better time to do it than do it now. And Stuart's been so kind and generous with his time to support physicians. I don't necessarily like to endorse one thing or the other, but I can tell you that, you know, as a physician, as a surgeon himself, as an ophthalmologist himself, as a teacher himself, I think he really gets what the needs are. So I appreciate you being here, Stuart. I think you and Valentina are going to tag team on how we can use these models. And I think we're going to have Nicole then to talk a bit about how she's applied this to certain techniques. So thank you, Valentina and Stuart, for being here.
Yeah, thanks for having us. So hello, everyone. As Dyke said, we will be showing some of the Simuli models. There are a lot of them, so I encourage you to go to the website, simuli.com. And if you go to products, you can see all the models. It also comes with a nice video showing you how to use them as well as how to put them together. So let's start with a couple here. If you're just starting to do cataract surgery, there are a lot of models that would help you with essential steps for cataract surgery. We have the simulorhexis, the small pupil, and the aphakia one. For the simulorhexis, it's a great one for practicing capsulorhexis. It also comes with a few films, so you can buy like the 5 or the 10 and you can try at different times. It's also pretty cool because you can kind of push the pressure of the capsulorhexis of the bag, so it can bring it up, and that can narrow the chamber, and it will make it a little bit harder for you, so you can practice different settings. As well as it will be a little bit easier for the capsulorhexis to run out, so you can also practice a little bit of those rescue maneuvers. For the small pupil, you can practice using different devices such as the Malugan ring, the eye ring, or even using the iris hooks. And with proper care, like not trying to tear the iris, you can actually use it multiple times as well. And for the aphakia lens, that's comes with a capsular bag, an empty capsular bag, and you can pretty much try practicing implanting intraocular lenses as well as using capsular tension rings and capsular hooks. With that, Stuart, would you like to add anything else before we proceed with the videos?
Yeah, thanks, Valentina. That's a great summary. And first, I just want to say, you know, Ike and everyone, thank you for having me here. It's really an honor to be with you guys and to be able to show you what I've been working on for the last 10 years of my life. And these things started off very rudimentary, and we've got them refined to a level where I really feel like they're providing value now to the ophthalmic community. You know, what is absent from our portfolio that we're working diligently on is our actual phaco model, but we have everything around that. So for cataract surgery for beginners, we have these important models, and then you'll see the more advanced models. And we will get the phaco model for actual, you know, nuclear dissection, nuclear emulsification, and chop techniques and things like that, but that's still in process. But I think to give you guys an idea, we can show some videos, like with the simulorhexis, you know, you can do basic techniques, and then you can also do more advanced techniques. We're just going to show a couple basic things here. On this particular model, it's important to initiate with a cystotome. It just works better. You can do it, but here we initiate the tear. We've got viscoelastic in the eye, and then we're going to grab with a forceps, and you see we're leading the tear, and everything's opening up nicely. We're tracing the tear, and it's opening up very nicely. Now we're increasing the pressure. We're going to rotate the eye, increase the pressure, and now as you see, as we open, it just wants to run outward. The video is a little bit laggy for me, but you're going to see a rescue maneuver here, so we can actually practice the little rescue maneuver, and we'll do that rescue again. At least on my end, it's kind of laggy, but hopefully you can appreciate it, or just go to the website and you can see the videos there. But you can practice different techniques. You can practice under normal tension. You can practice with increased posterior pressure in a shallower chamber. You can try a double rhexis technique. You can spiral outward. You can, of course, do the rescue maneuvers. So a lot of practice can be made. And even for beginning surgeons, without even touching the capsule, you can work on things like entering and exiting the eye with viscoelastic or with the instruments, and learning to pivot in the incision and not hit the ends of the incision and make the eye walk away from you. So a lot of things can be done just even before you touch the capsule. And then of course there's videos that show how to replace the capsule and start over and do multiple times. So that's the simulorhexis. That's kind of what started it all. It was because, you know, I was struggling with that technique, and I wanted to develop something, and then I wanted to share it with residents. And that's really what launched this whole Simuli project for us.
It's amazing how it mimics the real capsulorhexis. I love this one. Next video.
Yeah, let's show the small pupil. Yeah, so basically we did this eye initially for MST in the Malyugin ring, and here I am kind of copying Boris's technique of how he likes to implant the ring, or at least what I saw in his videos. And the iris is never going to be human tissue-like, but you can see that it shows all the steps of what to do when you want to implant and also explant the lens. And this model, there's really nothing consumable, so you can do it over and over multiple times. You don't want to do a rhexis on that film, you just want to leave it intact. But putting the viscoelastic in, elevating the iris, getting the hooks in, getting the scrolls to attach, and then also the explantation with or without the injector cartridge. You can just really practice over and over again and get very comfortable with it, because the last thing you want to do is go into a surgery with a new device or technique and have to try it for the first time on a patient. I think in this day and age, there's very little reason to do that. There are ways to practice it in a much more realistic setting to get all the major steps down.
Yeah. Then once you master your basic cataract surgery skills, you can use models for more advanced procedures. For example, you can use the MyLoop that Stuart will talk to you a little bit more. You also have an anterior vitrectomy one, which is great because you kind of can use this model to feel more comfortable with the vitrector. You can try the settings like IA cut or cut IA and really tell the difference about those two. It also allows you to use the vitrectomy via pars plana approach. And then this lens has been very popular because it allows you to do a lot of things. It's the iris fixation and IOL fixation. And basically the iris is pretty flexible. So it lets you can cut it, you can pull it and cause an iridodialysis. And with that, you can practice different techniques for repairing. For example, you can use the Mac-Amid or Mac-Anil, the Stipster sliding knot, the single fourth row pupilloplasty. And as I said, again, you can pull it and cause an iridodialysis and practice an iridodialysis repair with any technique like the handbag technique. And also what's really cool is that you can also practice a lot of IOL fixations. You can suture an IOL to the iris or to the scleral wall, or even an intrascleral fixation such as the Yamane technique. And Nicole will be able to show you all of those later.
Yeah, and just to add a quick word here, in some of these models like the AVIT machine, the AVIT model, obviously you need to be in the OR with your machine set up and anterior vitrectomy set up. But with the iris suturing IOL fixation, you just need your microscope and some instruments and an IOL and lenses and sutures and things like that. So it doesn't take a robust setup to work with those. The MyLoop eye I worked on for 2 years to really get the capsule to be robust enough to work really well with the MyLoop device. So if you've done MyLoop cases, if you have access to a MyLoop handpiece, maybe you've used one, you save it, you clean it, you can use it on the model eye. It's really nice that you can load a lens into the capsule and use the MyLoop to really get the feel and the sense of where the wire is and spin the lens and quadrant it. And when you pull the cap off, it's kind of very rewarding to take out the sections and see how well you did. The AVIT model, we're going to show a quick video of that. Really, the main function of this is to teach surgeons, residents, fellows, any surgeons that are not that comfortable with anterior vitrectomy, the main difference between the settings of vitrectomy setting versus the typical IA cut versus I cut A. So it's really important we help teach that you really want to be on the cut setting before you aspirate so that you're not pulling on the vitreous. We'll show this video clip here. It's also on the website, it might load better there, but you can see there's a rent in the posterior capsule, there's a plume of vitreous coming up into the anterior chamber. And then here we are with the eyes. We can go bimanual through the limbus, or we can go through a pars plana approach. And here we are, you can see we're tugging on the vitreous. We're in IA cut here. So we're aspirating before we're cutting, and that tugs on the vitreous and the vitreous base, which is not what we want. And as soon as you go into, you change the mode and you go I cut A, well, now you can clear the vitreous, and it's particulate identified, so you can already see it. We're putting some Kenalog in here, or triamcinolone, to kind of further identify if there's anything left over. So all these different maneuvers can be appreciated, and then you can see that the single port is in the pars plana area. So it is a single-use consumable eye, but you can get quite a bit of practice if you have, especially if you have some skilled surgeon with you, teaching you the settings and what you're watching and how to perform the maneuvers. It's very, very beneficial. And then just go back for a second on the ISIF model. Nicole's going to show some of the more advanced techniques on that. There are a bunch of videos on the website, but we're going to leave the videos to Nicole. And I think she has another video, another eye that we don't have on here for artificial iris implanting. So she's going to show those. Then we can go to the last ones. We have a lot of other models as well. Not everything's being shown here. Just other things for cataracts. The femto model is amazing because, you know, I really worked hard on this to work with the 3 major laser platforms that are out there now. In our surgical center, we have the LensX, and we also got the Catalyst. And so I was able to refine it for those, and also the Victus platform. So we have a specific kit, and it's great to have in a surgical center because there's always turnover of technicians or new doctors coming in that maybe haven't used femto and want to get up to speed. And so the reps can come in and train on these models, or the technicians can train after hours. And it's very realistic. We made it so that, you know, basically it tricks the OCT software into thinking that it's an actual eye. So all the fits work. You can work with the software and really understand how to use your laser and your software, so you're not trying to fiddle with it when you have a patient there. Become familiar with the software when the patient's not even in the room. That's such a big advantage of being able to work with these anytime. Something like the Zepto model, that's, you know, we provide that as a benefit to that company. That's not something an individual would get, but it really does give a realistic hands-on experience. A lot of these models we develop in conjunction with the company, you know, either before or right after the release of the product to get it dialed in to show all the teaching steps that they want.
Yep, and then we got mixed. So all the minimally invasive glaucoma surgery, there's a lot of models that you can pick from. There's one specific per model. For the KDB, for example, you can have a realistic trabecular meshwork, and you can visualize it with a gonio prism, and then you can just use that. You will need, for each of these, you'll need the mix. But for that one, you can just strip the TM, and you can use it multiple times just by using different clock hours. For the ABIC eye track, it has a pre-placed opening in the pigmented trabecular meshwork where you can just insert it and just keep wiring the catheter, and you can see the light through this model. And it can also be used multiple times. And for the iStent inject, Stuart joined Glocos, and that's the one that they did together. For all this mixed procedure, it will be good to have the mixed kit, because that comes with that platform where you can provide any tilt. It comes up to 30 degrees, which kind of simulates the turn head position of the patient. And it also has this reusable base unit, which you can use it in order to put the mixed model, such as the KDB, the eye track, and the iStents.
Yeah, that's a fantastic overview. I don't have too much to add other than we worked with all of these companies, LX, New World Medical, also MST, because they have the Trabectome now, or Trabex, Trabex Plus. The KDB eye and the Trabex eye are basically identical. They work very, very similarly. And then the iStent inject. And any of these companies, if you have access to your local reps, you can contact them when things open up and you want to get trained on them, because you're going to need the device, right? You're going to need the iStent inject or the KDB blade or the eye track. The simplest thing is obviously the KDB or the Trabex blades. You can probably access those and then just get the kit and the eye. But for the other ones, you're going to need more tools. So you might want to reach out to the companies directly, and they'll bring in the models, and they'll bring in the devices as well to train you guys. I think we have a video just to show the KDB in action. Yep, so here we are. You know, the eye is, you fill the eye with visco and put visco on the surface, and under prism visualization, direct gonio visualization, lots of different techniques. This is the one that we were just showing at the time, making initial goniotomy there, and then completing it with, you know, excising the trabecular meshwork. And obviously you can rotate the eye, and that meshwork exists 360 degrees around the model. So you can rotate it and practice it, you know, many more times before that model is consumed.
So there's even for laser. So if you want to practice YAG, SLT, or LPI, there's a model for that. For the YAG, it will come with an anterior capsule. It will come with the intraocular lens and then a posterior capsule. And that posterior capsule will respond to the ND YAG laser. It is single use, but you can just use multiple areas. For the SLT, it has a pigmented angle structure, which will release the pigment when you shoot it with the laser. And it would also come, whenever you shoot it and you're pointing at the TM, it will come with champagne bubbles. So pretty similar to what real life. And then for the LPI, it has 4 treatments in the iris. And once you do it, if you do transillumination, retroillumination, then you will see that that area transluminates.
Yeah, that's a great overview. Basically, they all have a consumable element, but you get lots of shots out of each one. And you know, you do need a stand that goes on the slit lamp that will hold any of these eyes with the suction cup. Oh yeah, there it is right there. So just make sure if you're going to do the laser, start with, you know, get the stand for any of those models. You know, these eyes came out of when I was a resident. I didn't want to sit down with a laser. I didn't get that much experience with the laser beforehand. So I would like tape up cards, or I would get some old IOLs and put them in front of the laser, and I would see how many times I could pit them and crack them and what kind of energy it took. And so these models kind of developed, you know, the YAG model certainly developed out of that. And I think we have a video to show of some of the lasers just quickly. We won't show this whole thing, but so you can see the anterior capsule, you can see the posterior capsules. It's very opaque in this model, but that's because that material expands with the laser. So you can see the Heaney beams, and when we hit the right focus, it opens, and it's actually a really fun thing. But really the use of this is, again, just like with the femto models, it's a chance to really get to know your instrument, get to know the offsets, the power settings, where the illumination is, so that you're not fiddling with these things, you know, as a resident when you have your patient in the room, or asking your senior resident or attending, you know, what power should I use, or things like that. So these models are designed to work with appropriate power settings when it's the YAG, SLT, or LPI. So here's transitioning to the SLT. There's the pigmented meshwork, and you know, it's easily identifiable, and you can focus on it. And then when we treat, it depigments. Now that's not terribly realistic, but we did that because it shows where you've treated. So when you're rotating the prism, the mirror prism lens, you can kind of help find your space and know when you're treating, you know, 180 degrees versus 360, and learn how to rotate that. So, and you do see the champagne bubble effect come up with each treatment. So as you dial up the energy, more champagne bubbles. So we got it to work with realistic power settings on all these models. Those are just some extras showing, like, you know, for any of the anterior segment eyes, you want to have a base plate. It's heavy. It keeps the eye from moving, and that vinyl sticker there provides a nice platform for the suction cup. So you're not fiddling with the eye and trying to hold it in place. It just, you know, have something like a stable platform like that. And we also recommend a surface coating gel to help cover the eyes. It helps prevent bubbles formation, because that's always a kind of a challenge with some of the model eyes. It can be used as a viscoelastic agent on the surface. We have a visco agent as well. It's not recommended really for the simulorexis model. We're working on something that's more thin and realistic, but so if you have access to actual viscoelastic when you're doing the simulorexis, I would recommend sourcing that. But you know, you could use this surface coating gel as an option as well. So
that's what we have. So we actually made a big order of these, and they should be coming up soon. All the fellows are very excited.
Oh, good. Yeah, I know we sent that off, so it should be there very shortly.
Hey, thank you so much, Valentina and Stuart. I'll let Nicole load up her slides while we're just chatting a bit. But yeah, I mean, I think that these have become really indispensable for early trainees, those that are refining techniques, and then for learning new complicated procedures. And Nicole, who I've known for a number of years and got to know a bit more this year, wonderful person and great surgeon, really smart. And I kind of wondered, I mean, is there a role for these kind of devices for a very accomplished surgeon like Nicole? And Nicole shared some videos in the past about how she's learned some of these complicated procedures doing them in the lab first. And so, Nicole, thanks for sharing about your approach for learning new techniques. And I think this is a very common question we get. I mean, you know, how can I learn a new technique while I'm waiting, while I'm off? I think your stuff, will be really helpful here. So thank you for being, Nicole. We always love to have you as part of our rounds. You're kind of an adopted faculty here.
Thank you. Well, it's an honor to be here, and thank you so much for putting these on to keep our skills, you know, and our mind and our hands working together and thinking together. I want to just say a little bit about Stuart. You know, I've known Stuart for 12 years now, and I have no financial interest in anything as part of Simuli, but I've watched him work tirelessly to come up with these models just out of his curiosity, his intellectual prowess. He's just an incredible person, and we thank you. I know I've become a better surgeon, and I've been able to be an early adopter because of your models, so I really appreciate it. We're going to talk about learning new techniques and whether or not these new techniques can actually help us. These are my financial disclosures. One of the biggest techniques that has come out since, you know, about 2017 was when Shin Yamane won his award, was the Yamane technique of the interscroll haptic fixation. And I think everybody wants to learn these new techniques, and do the latest craze, but I think we have an obligation to our patients to do them safely. We're going to get into that in a second. I just put this video in of iridodialysis repair because Valentina was talking about this, and this is how you actually create the iridodialysis with this model. And then we're going to go ahead and go in with our 25 gauge needle and take a straight STC6 and kind of bend it a little bit and dock it in there. And so we're going to be about 1.5 millimeters back, but you need to look at the blue zone in the scleral spur. You want to be just anterior to the scleral spur in these cases. And then we're going to go ahead and dock and make a mattress suture. And the next thing I want to do with this is to learn, I don't know how to do the sewing machine technique. And so there's a wonderful sewing machine technique that you can actually take this model and learn that. So I just wanted to put this out there for you to see because Valentina mentioned that and I hadn't had iris suturing in this presentation. But let's get into the Yamane technique. So the first thing you do is we want to put a lens in the eye. And we do have some viscoelastic in. Then we're going to take this 30 gauge needle and we're going to be about 2 millimeters back and about 2 millimeters offset for our scleral tunnel. We're going to go in and we dock the first one. Now we're going to do the second one. And, you know, we used to go in through a paracentesis, just like this. And what I'm going to show you on the next video is how we learned that leaving the haptic out would actually make this easier because this proximal is much more difficult than the distal to dock. And so this is how I learned how to do Yamane before I did this on an eye. You can retrieve at the same time, or you can retrieve one at a time. Use low temp cautery to actually take and make a flange on the haptics. And then you just kind of sit there and look at it. And you want to see, and I'm going to pause this right here. You want to see that you have an equal amount of haptics sitting out with the IOL centered. Now, what we learned by using these practice models is that if the optic is all the way off to one side horizontally or nasally, then you know that you're not 180 degrees. If your tunnel is asymmetric, you're going to have the optic inferior or superior. And then if you have tilt, it's because you have asymmetric tunnel lengths. And so these are actually really important things to learn how to do. So here we have our flange. We're going to bury that in. And the one thing I would say about these models that is really important when you start using them is you're going to get bubbles. And so in order to avoid the bubbles is you want to put the viscoelastic over all your incisions to avoid bubbles coming in and out. The other thing I'll say about this model is that you need to have a longer diameter or length, sorry, of what we're actually going to make with our keratome because it is stiffer. It doesn't feel like an eye. It feels like plastic. But you can practice these maneuvers and have a really successful surgery. So the key points that I figured out, because in the beginning, I was getting a lot of tilt, I was having a lot of issues with centration, is that Dr. Yamane has this in his video, which is that the angle of entry of your scleral tunnel should be 20 degrees to the limbus. And this decreased my chances of having tilt. And I had much better results after I did this. So going back, using this model, figuring out where I was going wrong was really useful. So you see it in action. We're making that 20-degree entry of the scleral tunnel 2 millimeters back with a 2 millimeter tunnel. Sometimes it's 1.5. We're going to go in and we're going to point that haptic down and then level it out. And then we're going to do that on the other side. And what you'll see in this video is that now I make my incision, this is a scleral tunnel, but you make your incision a little bit more temporal. That's one thing to learn. The other thing to learn is that if you have a lot of chemosis, take the conj down, because if you don't, you're going to enter too soon and you're going to have asymmetric tunnels. And then we're going to do the same thing here, but being able to keep the haptic out and then delivering it is a lot easier than going through a paracentesis where you have decreased wiggle room to kind of get that parallel. And then we're going to bring it out and we'll go ahead and do the same cautery. You don't have to cauterize before you take the other side out, but I've had one pull through, so it's often useful to do that. And then it's better to probably take them out at the same time, but I'm always afraid something's going to happen. And then, so this is the point where we look at our centration to see if we're happy. So I kind of tuck one side and then the other. The other thing I do is actually take down the conjunctiva. I don't want to just think that the flange is buried in the sclera. I want to know that the flange is buried in the sclera because we don't want erosion over time. So it's looking in the mirror It's trying to better your technique every time. So I think, the checklist, you don't need that much to do this procedure. You want to have your, mark 180 degrees. You need posterior infusion or anterior chamber maintainer when you do it. These TSK thin wall needles are very good. And then you want to use something with PVDF haptics if you can, like the CT Lucia from Zeiss. But if it's not available, you can do it with the Z8 9003. But you really need, with the PMMA haptics, to have experience before you do it, because you can kink those haptics really easily. And then just that low temp cautery. So the next procedure that we wanted to learn, I don't know if anybody wants to comment right now, have any questions about those techniques. Ike, Stuart?
I think you showed it really well. I think one question that's come up before is how many times can you use like the eye? I mean, you showed the case you had there. I mean, can you do it multiple times? I mean, what have you experienced?
So, so you can open it up from the back and take the lens out from the back. I often just take it out from the front through my main incision, because I want to practice like folding techniques or cutting it, how to get it out nicely. You can take it out from the back. I've used the same eye at least 15 times because I can't always find Stuart to give me an eyeball. So I definitely have used these eyes over and over. The only thing that happens over time is when they're filled with gel, sometimes the gel dehydrates and it gets a little gross in there. So, if you're going to use it over 10 times, do it, a few times a week. It's probably won't last more than a month, right, Stuart?
Yeah, I think that's fair. I would say probably on that eye, don't open it up from the back, because we have the whole thing already pre-filled with gel, so you're not using tons of viscoelastic. But if you top it off from the front and put it in some like airtight container, that usually will work out pretty well. And also, if you're doing a lot of iris techniques, maybe you want to do the Yamane stuff first, and then if you're going to like put a cerclage or something like that, you'd have to remove some of those iris sutures if you're going to get the IOL back behind it. So just kind of plan out the order that you're going to use it in. But yeah, multiple procedures. I mean,
the hardest part about using these eyes is the bubbles, and like I said, sealing all of your incisions with some of that gel that you put on top is really important, and making the incisions bigger than you think. So even if you're making sclerotomies to try and do, Gore-Tex suturing or whatever, make it bigger than you think and mark them, because they have this memory on the sclera. The next thing I'm going to get into is artificial iris. We were fortunate to be part of this trial. Dr. Maskett and I were one of 2 sites in California. Kevin Miller was a site, and then there were 12 other sites. And Mike Snyder really pioneered bringing this to market as a breakthrough device. And it's hugely impactful in our patients' lives. What can you do with it? Well, you can put it in the bag, you can suture it to the sulcus, and you can do passive fixation. And so particularly with this technique, you want to practice it before you put it in. And so Stuart's developed this aphakic eye, anaritic eye, where you can practice putting in a CTR. You have to really overfill, and sometimes it gets stuck. Then we put in the IOL, because whenever you're putting in an artificial iris within the bag, you have to have a CTR so it doesn't buckle with the fibrosis. Then you trephinate the artificial iris, and this is the trifold technique. Put it in a silver series and kind of shove that in. And then as you're inserting, you want to twist it and make sure that the pupil is up. And then you want to stain the capsule, and Stuart has a stain on the capsule to make sure that you can see it and get that into the leading edge of the bag. It's super important. Then you take 2 Klugelin hooks and unfold it. When you're starting out, make your rexus 5.5 to 6 millimeter capsule rexus opening, and make sure that you don't oversize it more than 9.5 millimeters for in the bag. Yes, you might have a little bit left over where you have transillumination defects, but you don't want to struggle too much in the beginning when you're trying to learn how to put in the bag. And with this technique, I then took it out and repeated it, 12 times before I did it in an eye. And this is just one of those great useful models to go through the steps. First you put the CTR in, then you put the IOL in, then you stain the capsule again, then you overfill the bag, then you put it in. There's this overfold technique right here that after right here, okay, that you grab it with your 25 gauge, and then you're going to overfold it to decrease the relative diameter of the whole thing that you're trying to get in the bag. So you have, 9.5 millimeters and you have a 6.0 millimeter or 5.5 millimeter opening. You have to fold it to get it in. So I found that extremely useful. This is, what it's going to look like now in real life, where we're folding this up, and we're going to now practice it. And you see how you can get it in. We have trypan staining. We're going to get this thing in, but all of a sudden when you do it in a real eye, it just looks enormous. And you're like, how am I going to get this thing to unfold? And so practicing it beforehand allows you to have the proper manipulation. We're going to go in with 2 Kugeln hooks, and we're going to take this and unfold it. And then here's that overfold technique where you go in 180 degrees away and you basically overfold it so that you can decrease the relative diameter. So to finish off here with our last video, we're doing the Yamane technique. We're showing how we're about 2 millimeters back, 2 millimeters over, and 2.5 millimeters back to create that 20-degree angle to the limbus. We're going to show how look at what this is an analytic model. So you get to really see what the needle is doing. It looks pretty stable. It's not moving around a lot. Then when I pull that out, I get to see what's actually happening as I'm doing this technique. For suturing technique, we go ahead and mark. We're going to take the Gore-Tex and create these mattress sutures. This is off-label Gore-Tex TTC9 needle. We can then cut the needles off after we've loaded the iris. Here we're going to go 2.5 millimeters back and about 4 millimeters apart. And this is what I mean by making those sclerotomies. We want to make them a little bigger than we normally would with this model. And then we're going to kind of do this needleless recovery that we've seen through Ike's videos. I think I learned how to do this through watching Sam Maskett and Ike Ahmed's videos. And then we'll go ahead and fold this. And I can now do this through just a 3 millimeter incision with the inserter. And it's really an elegant procedure where you've done your IOL fixation, you now have an artificial iris in, and the patients do well. So in summary, I think practice makes perfect. I think you gain a lot of confidence when you're starting a new procedure, and you understand what materials you need by setting it up beforehand. And I think that this is overall better for surgeons and better for patients. So thank you so much.
Nicole, thanks a lot for showing wonderful techniques. I mean, we often see videos that look great. And by the way, I'll let Ravi load up his slides. Last but not least, we want to get Ravi Golan here. And I think those great surgical videos are a result of what you practiced on these artificial eyes. And I think they really help you to do it under controlled circumstances. And I congratulate Stuart again for producing, I think, the most lifelike eyes that are out there. And so thank you for doing that, Stuart. And thank you for sharing that. I do want to make sure we get Ravi in here. Ravi has been a regular attendee, and he's the senior secretary for ophthalmic practice at the Academy. Always has great perspectives on things. He's very active online as well, and I think you probably can see him in his virtual background. So Ravi, I know you have an Academy meeting at 5. Thanks for sticking around, buddy.
Thanks,
but give us some words of wisdom.
Okay, can you guys see me okay? You guys hear me okay?
Great, man. Thank you.
Yeah. No financial interest. Well, first I want to show a screenshot of a text message I sent to Ike Ahmed on September 6th. Dr. Valentina had, like, on her Instagram story, she posted a photo of a grand rounds they were having Wednesday. And I said, if you recorded your fellows' teaching sessions, would be a great global service. And a day later, Ike said, not a bad idea. So I don't want to take credit for these COVID webinars, but I think I planted the seed back in September.
You and COVID.
Yeah, me and COVID. Yeah. So I would recommend, my take-home message for my 5 minutes is that I would recommend picking up this 91-page book called Who Moved My Cheese? And this was a book published around 2000, 2001. And, you know, changes happen. We have to anticipate change, monitor change, and enjoy change. I think that I felt that this afternoon and through all the webinars, which is why I keep coming back. But we have to keep being ready to change. You know, there's a great book by Walter Isaacson on Leonardo da Vinci, and you know, this painting of Tobias and the Angel, I was really struck by the way Isaacson wrote about how you could see the power of the master-pupil collaboration in this. And Leonardo was a student in Verrocchio's lab at Verrocchio's studio, but the fish here and the dog here have been attributed to Leonardo. And you can see, for students of art history, you can see how this adds to the painting and to that genre. I just yesterday I pulled out all of my old videos and all of my old DVDs from residency onward. Back in 2002, ASCRA sent out a 1-hour video of Howard Gimbel doing live surgery. I think I've watched that video about 1,000 times. I've never had the honor of meeting Dr. Gimbel, but I consider him to be a mentor who I've never met. And basically, on the night before surgery for years, I would watch Dr. Gimbel do cataract surgery. I then went to Dr. McCool's office to watch him do surgery twice. And you could see the passion which they brought to doing cataract surgery and how they just made it seem so simple, and how cataract surgery became a great part of their life. So I've pulled out these old videos. I actually have one of these videos is the first time I dropped a nucleus. So I'm gonna go watch that from 20 years ago, and hopefully I'm gonna learn some new pearls and techniques. But up here in the upper right hand corner is a DVD which Uday Devgan sent me, and every day for about 7 minutes I watched Uday Devgan. He's a friend of many of us. Do his cataract surgery videos. I've learned watching cataractcoach.com has made me a better surgeon. And I took the plunge, and I was one of the first people to submit a video to Uday. And I think this is one of his first guest videos. But what I recommend especially to the young surgeons, is to send a video to an expert and have them review it. And in Uday's case, he'll make you look like a better surgeon than you are. And he'll always have a teaching pearl for all of us. So also on Instagram, I follow Instagram feeds. I think that a lot of colleagues around the world will show cases that we don't see in the United States. You know, a lot of all around the world, these are cases which I've learned a lot from. I've never met Dr. Jorge Calzada, but I consider him to be a mentor. His videos are excellent. His little snippets on learning. And I'm a cataract and comprehensive surgeon, but the retina, I've always been fascinated by the retina as well. So you could stay fresh there. One of my take-home messages is I'm trying to go back to original principles. So the Mayo Clinic, the ophthalmology department, has a resident course on suturing techniques. It's a four-part course. It's free. It's on YouTube. But I want to go back to original principles, to learn the principles again in this time of COVID, to master techniques of the surgery. So in this case, the teacher really does become the student. You know, I've had a chance to do some of the teaching at Wills Eye, and now we have this brand new lab at the Wills Eye Hospital. Here I am proctoring some of the second year residents, but I'm going to try to go back in the lab and again refresh on hand-eye coordination. I love this slide, which is the skill versus attitude model. And Matt Jensen, actually, he works with Dr. Buchdahl out in Montana, South Dakota. Out in South Dakota, he's their practice leader. But you can have someone who has lower skill and has a great attitude, and those individuals need training. Someone can have a high skill and poor attitude; those individuals need coaching. And I think that, you know, a few weeks ago we watched the webinar that Ike had with Ashley and others on going from good to great. And this is if you get a chance, this is the book you want to read if you want to get an MBA from home. But you have different levels of leaders. Level one is a highly capable individual, which many of us, which we all are. But we want to build enduring greatness through a combination of humility and professional will. And good to great, Jim Collins has these concepts of the flywheel and also the hedgehog concept, where you want to find what you're deeply passionate about, what you can do to be the best in the world at, and what drives your economic engine, your surgical engine. And that can, this whole concept of the flywheel, keep going to become great at something. Finally, I want to conclude with the 10 lessons from Benjamin Franklin. I'd have you look at the first two, really, is what these webinars have been all about: lifelong learning and self-improvement, and also the social charm and working hard. This is another great book I've read, and I don't want this just to be a book review, but basically, if you think outside the box as cataract surgeons and as anterior segment surgeons, the four laws of behavior change: make it obvious, make it attractive, make it easy, and make it satisfying to create better good habits during this time that we have together. That's all I have. You can build your own curriculum for lifelong learning, and that's all I got. I'm on Instagram and Twitter with the same handle.
Ravi, thank you so much, man. I mean, you are such a guy with great passion and knowledge, and I've always said that as you know, I called you the senator. I think you're a true senator in the sense of a statesman and a guide with a great moral compass, who's a great advisor to all of us and what you do and what you share. And I think you've just given us a lot of great ways that we can think about not only ophthalmology but about life as well. So your presence is always wonderful to have with us, and your words are very, very stimulating. So thank you for doing that. I know that you're busy and you got many things you're wearing your different hats with. So thank you for being here. And we always look forward to seeing Ravi Goel, you know, on our webinars and our rounds. And you are right. You were one of the ones who said we should do this globally. And I think you kickstarted the idea. So thank you for doing that. I wanted to open up, you know, just any last bit of questions. I know we had a lot of stuff covered. I really enjoyed both the glaucoma presentation. So thank you, Tissy, for doing that. And I really enjoyed the discussion and the conversation that everyone brought to the table about, you know, staying sharp in this time. If anything, everything you've heard today, you probably realize you don't have enough time to stay sharp, even though you have time off. And so that tells you a lot in terms of when you didn't have time, when you thought you didn't have time, and how it compares to now as well. So I don't know if anyone else wanted to add some closing thoughts. We've heard from all of you. Thank you, Havo and Arsham as well for starting it off, and of course Valentina and Stuart talking about the stimuli, and Nicole showing a great pros in terms of learning, and of course Ravi finishing it off with a really powerful you know, statement on continuing to learn and continuing to be great and pushing ourselves. So but thank you for that. I don't know, Jeb, did you have anything to add? Jeb, you've been doing this for a month now, and the idea really has been to kind of help transfer knowledge and skills.
Yeah, I think, you know, from all the feedback we've been getting, it sounds like we've pretty much been achieving it, and we're hopefully going to continue on and even add more value, right? So I think it's fantastic, just for the community sense as well.
And maybe you can put one last slide up just to remind everybody that making sure on Saturday at 12 p.m.
you guys need to
time, 9 a.m. in California, and your time, anytime, whatever time zone you're in. We're going to have an amazing Guardians of the Lens, which is going to be a great international event, intergalactic event of amazing proportions to talk about some really complex cases. It's going to be fast paced. It's going to be, you know, a little drama in there, and certainly a lot of characters at play as well, and a lot of people to manage. So it'll be fun. I look forward to seeing everybody there on Saturday at 12, either here on Zoom or on YouTube. And I want to wish again the speakers, you know, many thanks for spending your time with us, and the panelists for great conversations. And this is what it's all about. I'm sure that we will be back to work soon enough, and I hope we still keep in touch. But you know, it gives us great warmth to see your faces and see your names. For those of you who can't see your faces, here at least a couple times a week. So thank you again. Enjoy the rest of your day. Peace out to everybody. Thank you again for spending time with us, and I'll see you here on Saturday. Thank you.
Thanks, Ike.
Thank you, everybody.
Thanks, guys.
Thank you so much.
Guys.
Bye.
Thanks, everyone.
Thanks, everyone.